Welcome to Schein Chats. I'm Julie Johnson, your Surgical Solutions Manager for Henry Schein Medical's ASC segment. Today, I'm joined here with Dr. Rene Gonzalez. Welcome. He's a board-certified anesthesiologist with 35 years of clinical experience in both academic and community anesthesia practice. His lifelong areas of interest and expertise have been in patient safety, airway management, crisis management, and patient safety care. Dr. Gonzalez also invented the full-scale human patient simulators, SimBaby and SimMan. He's also founded and directed the University of Pittsburgh Human Simulation Center. Dr. Gonzalez, thank you so much for joining us today.
You're very welcome, Julie, and thanks so much for inviting me to chat with you this afternoon about such an important topic.
Yes, I'm happy to have you here. So one thing I'm very interested in, and I know that we've talked about before, is you've published numerous peer-reviewed medical content throughout the years, specifically on the topic of patient safety, and more recently on staff safety during upper endoscopies. What got you interested in these areas?
You know, Julie, I've always been interested for the entire 35 years of my career in patient safety, and I think the origins of that probably came, well, first from the Hippocratic Oath that we all take when we graduate medical school to do no harm, and also from my personal practice philosophy, which I call the golden rule of medical practice. I really try to practice medicine. I try to do unto my patients as I would want to have done unto me or unto my loved ones. I chose a pretty dangerous career in anesthesiology. It's pretty easy for us to do harm. Hardly a day goes by when we don't have a near miss. And sometimes really bad things happen. We use very powerful drugs and we do some pretty invasive techniques to the human body. And so it's very, very important that we always be patient-centered. And for those reasons, I've always striven to try to improve and really maximize patient safety. So I got interested in specifically patient safety during upper endoscopy a few years ago. My wife and I relocated to New Jersey to be closer to our extended families, and I accepted a position at a community hospital here in southern Jersey where I live. We have a very busy and active endoscopy suite. It's a hospital-based suite, but we do not only a lot of inpatients, but also a lot of outpatients for all sorts of upper GI endoscopies, routine esophagoscopies, upper GIs, also some more complex ERCPs. We do all of those in the endoscopy suite, and they're all done under sedation. So when you do a lot of these cases, you realize that even though endoscopies are often treated as quote unquote just an endoscopy, they're really, from an anesthesia point of view, very, very complex cases. From an airway management point of view, which has always been one of my professional interests. And they can be very dangerous cases, and I think they should be viewed as potentially very dangerous cases. The main reason for that is that a lot of these patients can get hypoxemic. That means their oxygen saturations can drop very, very low during the procedure. And there are a lot of reasons for that. So I don't know if you've ever personally had an upper endoscopy or if you have any family members that have, but we put in an intravenous, we take the patient into the endoscopy suite, we turn them on their side facing away from us, we put an oxygen device on them, and that's traditionally been nasal cannula, and we start to sedate the patient intravenously. Then we turn the lights off, either way down or off, so that the endoscopist can see the monitor screen. And then the endoscopist proceeds to insert an endoscope. So we insert that into the patient's mouth and down into their esophagus. So I tell people that's analogous to pushing a solid garden hose down into someone's upper airway and into their esophagus. And so most patients, they have a tendency to cough very, very vigorously. And as a result, in order to make it tolerable, we have to sedate patients. When we sedate patients, we always decrease their respiratory drive. So we press their respiration. We also relax the muscles of their upper airway so that their upper airway tends to collapse. So for those reasons alone, they tend to be very dangerous, potentially dangerous cases. Now, there are the most recent numbers, accurate numbers we have on GI endoscopies indicate that there were, back in 2013, 2014, there were 7.1 million GI endoscopies performed in the United States. That didn't include transesophageal echocardiograms by the cardiologist or bronchoscopies by the pulmonologist. So there are more upper endoscopies done in our country and probably in the world than just about any other medical or surgical procedure. That number greatly exceeds the total sum number of appendectomies, total joint replacements, tonsillectomies, and bariatric surgeries done in the United States. But again, anyone who's done enough of these, any anesthesiologist, any nurse, any endoscopy nurses really understand and appreciate that patients can drop their oxygen saturations.
Wow, that's a lot of great information. And ironically, I have had an upper endoscopy before, but I never knew, with this being the most performed procedure in a outpatient surgery center and in modern medicine, I never knew how much of a serious risk you could have just by having a routine upper endoscopy. So it sounds like you kind of mentioned the risk with hypoxia or low oxygen levels that clinicians and facilities face. Can you kind of talk a little bit more what you can do to kind of help protect yourself or from staff and a patient level from hypoxia or low oxygen during these types of procedures?
Yeah, absolutely. I'd be happy to. So traditionally, for many decades now, the oxygen delivery system that we've used has been nasal cannula, just a little nasal oxygen hose placed in your nose. The reason for that, even though oxygen face masks provide much, much superior oxygen concentrations than nasal cannula, in the operating room, we tend to use oxygen masks for everything because we understand and appreciate how much better oxygen delivery you get with a mask compared to a nasal cannula. But in the endoscopy suite, if you think about it, the use of oxygen masks has been precluded because the dome, the solid dome of the oxygen mask, prevents the insertion of the endoscope by the endoscopist. So we've had to settle for nasal cannula. Now, just to give you an idea, the highest oxygen concentrations that a nasal cannula can deliver in the best circumstances are about 35 or 40% oxygen. A simple oxygen mask, full face mask, can deliver 40 to 60%, and an oxygen mask with a reservoir oxygen bag can deliver 85 to 95% oxygen. So in spite of the fact that nasal cannula are so inferior, we've been forced to use them for all these years and for all these decades, just for pragmatic reasons. So in answer to your question, so a few years ago in the fall of 2018, I was approached, I was actually taking a little coffee break in our endoscopy coffee lounge, and I was approached by our nurse manager, Cindy Stagg, who was then the president of the New Jersey State Society of Endoscopy Nurses. And she invited me to give a lecture at their annual state conference. And I was about to, I accepted, and I was honored, and I was about to ask her what topic she wanted me to speak on when overhead on the hospital intercom system, they called a code blue to the endoscopy suite. And we were standing in the lounge in the endoscopy suite. So we ran to the room where there was a case in progress. And I ran in, and one of my colleagues is a very, very experienced, superb, board-certified, very attentive anesthesiologist, had a middle-aged patient who was not particularly sick, a history of hypertension, not much else in the way of medical problems, who was scheduled for what we call a double and upper endoscopy and esophagoscopy for GERD, and also after that, a colonoscopy. And in the very beginning of the case, during the upper endoscopy, the patient coughed, so my colleague gave more sedation. The patient stopped breathing or went into laryngospasm and started to desaturate very, very profoundly. And when I ran into the room, He was having runs of ventricular tachycardia on the EKG monitor, and his oxygen saturations had dropped first to the 50%, then to the 40%. Now, just to give you an idea, if I were to measure your oxygen saturation now, you'd probably be between 97 and 100%. The oxygen depleted blood that returns to our heart after being used by our organs has a saturation of 75%. That's considered oxygen depleted blood that needs to pass through the lungs to refresh and replenish the oxygen. And this patient's saturations were down in the 40 to 50% range, and the patient was having cardiac arrhythmias. So we were fortunately resuscitated the patient. We had to have the endoscopist pull the scope out. We took an ambu bag and very aggressively resuscitated the patient. We did artificial respirations. He came back, but he wound up having both of his procedures canceled. We had to transfer him to the ICU for further observation and evaluation. And as you can imagine, everybody was pretty shaken up by this, including the patients and the families that were in the waiting area and in the recovery room, either waiting to or recovering from their endoscopies. So when things like that happen, it's pretty serious. And of course, you worry about serious hypoxia damaging the heart and damaging the brain permanently. And this patient was quite somnolent and lethargic out of proportion to the amount of sedation he'd gotten after the procedure. So that pretty much cinched the topic that I was going to be talking about at that annual meeting, and Cindy totally agreed. So the evening before the meeting, I was thinking I had delineated all of the factors that I've mentioned to you that can result in profound hypoxia during upper endoscopy. But I was not very satisfied because I listed all the problems and the reasons for the problems, but I didn't really have good solutions other than, you have to maintain tremendous vigilance, use capnography to monitor the exhaled carbon dioxide, observe your patient carefully, intervene aggressively before the patient desaturates, but couldn't really offer anything new. So I said, let me do one more literature search before my lecture. And I was on my cell phone just scanning, just reviewing the literature again. I came across this little reference to a device. It was actually an ad in a gastroenterology journal for a device that I'd never heard of before. It was called the procedural oxygen mask. And I remember pinching open my phone, trying to get a better view because the picture in the little ad was tiny. I was trying to see what was special about this mask that made it a mask for endoscopy. So it turns out that it looks very much like a traditional oxygen face mask, except it's got a capnography port built into it, which is absolutely necessary for monitoring our patients. But it's unique in that it's got an oral and a nasal endoscopy port with these self-sealing membranes that allow an endoscopist to insert a scope, and yet you maintain a full oxygen mask. And when you use the reservoir oxygen bag, it can deliver oxygen saturations in the 85 to 95% oxygen range, which is just fantastic. So I mentioned that in my talk. The talk was very enthusiastically received. And after the talk, I said to Cindy, our nurse manager, do you think we can try to track down the local rep that might be able to get these for us? And she got to work, being the superb nurse she is. And by Monday morning, she had us our first case of procedural oxygen masks, otherwise known as the POM. The first patient I used it on was a patient with known severe obstructive sleep apnea who was morbidly obese. And I was so impressed. I maintained his oxygen saturations near 100% for the whole case. And it was a pretty long and complex upper endoscopy. After that, I realized that it's not just the morbidly obese patients with lung disease or with sleep apnea. A lot of the patients that desaturate are the younger patients that have very active upper airway reflexes and require a lot of sedation. So I started using it. That was in the beginning of 2019, January of 2019. I started using it routinely, and it just made a world of difference. A few months later, I published my first few articles on the topic. And then our local rep actually put me in touch with Mr. Joe Voss from Palm Medical, which is a small company in California. And we started to talk. And ever since then, I've been serving as an educational consultant for POM. But I told Joe that this was a game changer. It was really a revolutionary device. It was the biggest advance that I'd seen in anesthesia for upper endoscopy in decades, truly.
Yeah, and there's no doubt with COVID-19 that there's been a huge impact on both staff and patients as it relates to these procedures. And we too at Henry Schein have seen great success with the palm mask. And I definitely appreciate you taking the time here, Dr. Gonzalez, to share your experiences and your feedback with staff and patient safety related to airway management. So thank you
Yeah,
again, Dr.
you're
Gonzalez.
welcome. If I can make one quick comment, Julie, about what you just brought up about protecting the staff. So a couple of months before the COVID pandemic hit, it occurred to me that I was using the palm routinely, and there was this very pleasant side effect. Patients weren't coughing in our faces during upper endoscopies and in the recovery room after endoscopies, because that's nearly a universal phenomenon. And then the pandemic hit. So I wrote this up in an article in the Anesthesia Patient Safety Foundation newsletter, and realized that not only does the palm mask protect patients from profound hypoxia, it also protects the staff from aerosol generating procedures, which now are understood to be the main source of spread of COVID-19. So it's a tremendous dual function that these endoscopy masks serve.
Yeah, that's very good info, and I definitely appreciate you being here and
Sure.
sharing this with us. So thank you again for taking the time and for everything that you do, and we will see you next time on Schein Chats.
My pleasure. Thank you very much, Julie. It's been a pleasure. Have a great day.